Imagine for a second that you are, well, in absolute peak physical condition.
Right, like you're a professional athlete at the top of your game.
Yeah, exactly. Maybe even a gold medalist. And you undergo this fairly routine foot surgery, and the operation goes perfectly.
Mm-hmm.
You go home to rest. But then, days later, you find yourself struggling to breathe, literally fighting for your life in an emergency room.
And it's not because of an infection or anything like that.
Exactly. No infection. You didn't tear a muscle.
Oh,
You were being taken down by something completely invisible. It's this microscopic threat that formed entirely because you did exactly what you were told to do.
which is to stop moving.
Right. You stop moving.
It's honestly one of the most counterintuitive paradoxes of the human body. I mean, we are conditioned from childhood to believe that resting is the ultimate form of healing.
Right. You get hurt, you go to bed.
Exactly. But in the context of human circulation, absolute rest can actually be the very trigger for a catastrophic medical event.
And that is the exact paradox we are diving into for you today. Welcome to the Deep Dive. We have this fascinating stack of sources in front of us today. We've got nursing protocols, some wild historical medical cases, and modern clinical trial data.
It's a really comprehensive pile.
It is. And our mission today is to explore this concept, the clot that forms when you stop moving. We are talking about deep vein thrombosis, or DVT. So, okay, let's unpack this.
Let's do it.
Looking at these sources, they draw a very hard line between different types of veins. What exactly is a DVT, and why is it so much more dangerous than just getting a bruise or a surface-level clot?
Well, the distinction is purely anatomical, but it really makes all the difference in the world. A deep vein thrombosis is a blood clot, or a thrombus, that forms inside one of the body's deep veins.
So, like, where exactly?
Typically, these are buried deep inside the muscle of your calf, your thigh, or your pelvis. So if you think of the veins just under your skin as small, winding side streets.
Okay, side streets.
Right. If a clot forms there, yeah, it's painful, but it's relatively contained. The deep veins, on the other hand, are the massive high-speed return highways.
Oh, wow.
Yeah, they're responsible for channeling huge volumes of oxygen-depleted blood directly back to the right side of your heart and then immediately into your lungs to get reoxygenated.
Which means if a clot forms on that high-speed highway, there is no detour.
None at all.
If a piece of that clot breaks off, like it embolizes, right? It has a straight, unobstructed shot right into the heart and then into the pulmonary arteries.
Exactly. And when it lodges in the lungs, it completely blocks blood from picking up oxygen.
Right.
That is what we call a pulmonary embolism, or PE.
And that can be instantly fatal.
It can. In modern clinical practice, doctors actually don't even view DVT and PE as separate diseases anymore.
Really?
Yeah, they group them together under the umbrella term venous thromboembolism, or VTE, because honestly, they're just two stages of the exact same disease process. The clot forms in the leg, and it basically finishes its destructive journey in the lung.
Wow. So the entire goal of modern medicine, and really the main through line of all the nursing protocols in our sources today, is early recognition and prevention.
Prevention is everything here.
It's about understanding that something as basic as, bending your knees and walking is literally a matter of life and death. But to figure out how to stop these clots, we first need to understand the blueprint of how they form.
Right.
And reading through these historical documents, I was genuinely stunned to see that the prevailing theory on this isn't from modern times at all. It's from the 19th century.
Yeah, it's pretty wild. Despite all our advanced MRIs and, genetic sequencing, the foundational framework for understanding blood clots was actually established way back in 1856.
1856.
It's incredible. By a German physician and pathologist named Rudolf Virchow. He basically proposed that for a clot to form inside a blood vessel, one of three specific conditions had to be met.
And this is Virchow's triad.
Exactly. We still call it Virchow's triad today. It is literally the first thing taught in every single medical and nursing school when covering this topic.
So let's break those three conditions down because they really dictate everything else we are going to talk about today.
Okay, so the first pillar of the triad is stasis.
Which means?
This is simply blood flow slowing down to a crawl. The second pillar is endothelial injury, which means physical damage to the smooth, delicate inner lining of the vein itself.
Okay, stasis and injury.
Right. And the third is hypercoagulability. That's a systemic state where the blood's chemistry is altered. So it makes the blood fundamentally primed and eager to clot even when there is no physical bleeding to stop.
Okay, I want to linger on that first pillar for a second, stasis. because it really highlights the mechanical engineering of our bodies.
Oh, absolutely.
If you think about the blood in your legs, it has a massive problem to overcome, which is gravity. It has to travel all the way from your ankle back up to your chest. And your heart alone just isn't strong enough to suck that blood upward.
No, it's not. So your body relies on your leg muscles, specifically the calf muscle pump. The soleus muscle in the calf is actually often called the second heart for exactly this reason.
The second heart, I love that. It's basically a biological plumbing system.
Huh.
Every time you take a step, that calf muscle contracts and physically squeezes the deep veins, just shooting the blood upward.
Mm-hmm.
And then these little one-way valves inside the vein snap shut so the blood doesn't fall back down.
Yeah.
But when that pump is turned off, like when you are immobilized in a hospital bed or sitting at a desk for 12 hours, the blood just pools.
It just sits there.
Right. If a plumbing pipe has a fast-flowing river of water, it stays clean. But if the water stops waiting, all the heavy sediment, the debris, the clotting factors, they all start to settle against the walls of the pipe.
And that sediment settling triggers a microscopic chain reaction.
Yeah.
And that cascade is dramatically accelerated if you introduce the second pillar, which was endothelial injury.
So physical damage to the pipe itself.
Exactly. If you undergo surgery like a knee replacement, or if you suffer trauma in a car accident, the lining of your vein is damaged. When that lining breaks, it exposes a protein underneath called tissue factor.
Tissue factor.
Yeah, and tissue factor is basically a biochemical alarm siren. It screams to the rest of the body, hey, we're bleeding, send the clotting crew right now.
Wow.
So even if the bleeding is purely internal, a clot will rapidly build at that exact site of injury.
So, I mean, if your pipes are flowing and the pipes aren't physically damaged, you should be completely safe from a clot, right?
Well, you'd think so.
Right, but that brings up the third part of the triad, hypercoagulability. Because what if the fluid running through the pipes is genetically primed to basically turn into sludge?
Exactly. Sometimes the blood itself is the core problem. Our sources highlight a condition called factor V Leiden. It was identified in the mid-90s, and it's a genetic mutation that essentially breaks the off switch for blood clotting.
The off switch.
Yeah, so people with this mutation create clots much faster than their bodies can dissolve them. But the thing is, hypercoagulability doesn't have to be genetic. You can acquire it.
How does that happen?
Things like active cancer, systemic inflammation, or severe obesity can all basically dump chemicals into your bloodstream that lower the threshold for clotting.
And looking at this 165-year-old triad, it completely destroys the modern stereotype we have about who actually gets a DVT.
Oh, completely.
I think the average person assumes this is a disease strictly for the elderly or maybe someone confined to a nursing home. But Virchow's triad proves that age is entirely irrelevant if those conditions are met.
The triad does not care how young you are. It doesn't care how fast you can run a marathon. If the scales tip, a clot forms, period.
The story of David Bloom in our sources is just a heartbreaking example of this. He was this incredibly prominent, dynamic NBC News correspondent. And in 2003, during the invasion of Iraq, he was embedded with U.S. forces.
Right.
He was only 39 years old. But he spent days folded up with his knees to his chest inside this cramped Bradley fighting vehicle just bouncing across the desert.
He had almost no ability to extend his legs or activate that calf muscle pump we talked about. The stasis was absolute.
The pump was turned off, the sediment settled, and a massive DVT formed. And it eventually embolized into a fatal pulmonary embolism. I mean, he wasn't elderly, he wasn't sick. It was pure stasis-driven thrombosis caused entirely by his environment.
And we see this phenomenon regularly at the extreme opposite end of the health spectrum, too, like in elite professional athletes.
Right, going back to the surgery example.
Yeah, the tennis legend Serena Williams developed a life-threatening pulmonary embolism following foot surgery in 2011. And she was arguably in the top fraction of a percent of human physical fitness.
Truly peak condition.
But the physical trauma of the surgery created endothelial injury, and the prescribed recovery period created stasis. So 2 pillars of the triad were met, and her incredible fitness just couldn't stop the clot.
Chris Bosh is another prime example from the sources. He was an NBA All-Star, constantly moving, but his career was tragically cut short by recurring blood clots.
Yeah, he had an underlying hypercoagulable state.
So you combine that with the constant microscopic physical trauma of professional basketball and the endless hours sitting on airplanes, and boom, you trigger the triad.
Exactly. And if we connect this to the bigger picture, the realization that prolonged stillness is deadly forces us to look back at medical history with a lot of horror.
Oh, totally.
Because for a very long time, the medical establishment was prescribing the exact thing that was killing people.
The era of strict bed rest. Reading these older protocols, it is wild how universal it was.
It was the standard for everything.
Right. For much of the 20th century, if you had a baby, you were on strict bed rest. Heart attack, weeks of bed rest, surgery, do not move a muscle.
The logic was that a recovering body needed to conserve every single ounce of energy to heal tissue, and moving might, rip open surgical stitches.
It was incredibly intuitive logic at the time.
It was. But the outcomes data eventually revealed an absolute disaster. Doctors were noticing horrifying rates of sudden death in patients who seemed to be recovering perfectly from their initial surgeries.
And they didn't know why.
Not at first. It took decades of autopsies and outcome tracking to realize that the bed rest was allowing massive clots to form in the deep veins. Orthopedic surgeons were actually some of the very first to sound the alarm on this, particularly as joint replacements became more common in the mid-20th century.
Because replacing a hip or a knee is basically a worst-case scenario for the triad, right?
Yeah.
You have massive bone and tissue trauma causing endothelial injury, plus the patient can't walk.
Precisely. The DVT rates in early orthopedic surgeries were astronomical, and this realization forced one of the most profound paradigm shifts in modern nursing and medicine.
Right.
Immobility went from being a prescribed treatment to a recognized pathogen. Today, if you wake up from a major surgery, a nurse is likely going to have you standing up and shuffling down the hallway within hours. Early mobilization is now the ultimate protective standard.
But wait, let me push back on that for a second.
Sure.
If getting up and moving is the cure, if activating the calf muscle pump sweeps the sediment away, why do the nursing protocols in our sources still mandate heavy blood thinners for patients in the hospital?
That's a great point.
I mean, if I am walking the halls, why are they injecting me with anticoagulants? Doesn't the walking basically cancel out the need for the drugs?
It raises an important question, but the flaw in that logic goes right back to Virchow's triad. You cannot view the triad as a single problem with a single solution.
Ah, okay.
Walking down the hallway absolutely solves the stasis problem. But what if you just had major abdominal surgery? You still have immense endothelial injury that is actively calling for clotting factors. Or what if you are hospitalized for cancer treatment? Your blood is still hypercoagulable.
So the movement only fixes 1/3 of the blueprint.
Yes, exactly. Walking cannot fix a chemical imbalance or a torn vein lining, and that is why mechanical prophylaxis like walking and chemical prophylaxis like blood thinners are not substitutes for one another.
They work together.
They do. Medications like heparin or the newer direct oral anticoagulants work synergistically with movement. The movement keeps the blood flowing, and the medication alters the blood chemistry to raise the threshold for clotting, preventing that tissue injury from triggering a massive response.
Okay, so what does this all mean for things like compression socks? Because for years, the conventional wisdom was just to put tight stockings on immobilized patients to keep the pressure up and prevent stasis.
Right.
It seems like a perfectly logical physical solution, right?
It does seem logical, and for decades, graduated compression stockings were used as this blanket preventive measure for almost everyone in a hospital bed. But the medical community eventually learned that you cannot just slap a mechanical Band-Aid on a complex system without testing it rigorously.
And that's where the CLOTS trial comes in.
Exactly. The UK Clots trial in the 2000s completely upended this assumption.
So what did the trial actually test?
They looked specifically at stroke patients. Now, stroke patients are highly vulnerable to DVT because they often suffer from paralysis and simply cannot move their legs.
So ultimate stasis.
Right. The researchers assumed thigh-length compression stockings would artificially squeeze the veins and prevent clots, but the data showed the exact opposite of what they hoped.
Wait, really?
Yeah. Not only did the stockings fail entirely to reduce DVT rates in these stroke patients, but they also actively caused harm. The constant tight pressure on fragile skin led to terrible ulcers, skin breakdown, and even restricted arterial blood flow.
Oh man, that is a massive backfire. Trying to passively squeeze the leg ended up causing a whole new set of injuries.
It forced a total reevaluation. It taught clinicians that you just cannot apply a universal passive fix to every single patient. Prevention requires an active, tailored approach based on individual risk factors, not just handing out tight socks.
And the urgency of getting that prevention right is magnified by how sneaky these clots actually are. Because even with early walking and even with blood thinners, a clot can still form.
They absolutely can.
And the most terrifying detail in these sources isn't just that they form, but that they often form in complete silence. There is this huge misconception that a DVT will always present as this massive, red, swollen, throbbing leg.
And that expectation is incredibly dangerous. While a classic DVT certainly can cause swelling and pain, a huge percentage of them are completely asymptomatic.
Just zero symptoms.
Zero. Or the symptoms are so mild, just a vague ache or a feeling of heaviness, that a patient will completely dismiss it as a muscle cramp or a pulled hamstring.
Wow.
Very frequently, the absolute first sign that someone has a DVT is when a piece of it breaks off, travels to the lungs, and they suddenly collapse with crushing chest pain and shortness of breath.
The silent nature of the disease is just deeply unsettling. But historically, that silence has also served as a very dark warning sign for other hidden diseases. There was a story in our sources about Armand Trousseau, a French physician in 1865.
Trousseau is a fascinating figure. He was a brilliant diagnostician studying thrombophlebitis, which is basically inflammation and clotting in the veins. And during his practice, he noticed a very strange pattern in a subset of his patients.
What did he see?
They would develop unexplained blood clots that would appear in one leg, resolve, and then spontaneously appear in an arm or the other leg.
Okay, so just popping up everywhere.
Right. These migrating, recurring clots were happening without any obvious stasis or injury.
So he realized he was looking at severe hypercoagulability.
Yes, and he made a groundbreaking connection. He discovered that this specific pattern of migrating clots was often the very first visible symptom of an occult or hidden visceral cancer, most notably stomach or pancreatic cancer.
Because the tumor is changing the blood.
Exactly. The tumor itself was secreting chemicals that threw the clotting cascade into absolute overdrive. Today, this phenomenon is still taught in medical schools as Trousseau's sign of malignancy.
But the truly chilling part of the story is how his research ended.
It is incredibly tragic, honestly. Just 2 years after publishing his findings in 1867, Trousseau felt a strange ache in his own body. He observed his own veins and saw the very pattern of migrating blood clots he had just documented.
Oh my God.
Yeah, because he wrote the paper on it, he knew instantly what it meant. He used his own physical symptom to diagnose himself with advanced pancreatic cancer, and he succumbed to the disease just months later.
The clots were the smoke and the hidden cancer was the fire. It is an amazing testament to the power of clinical observation. But obviously, how we look for that smoke has evolved a lot, because back in the 1940s, a doctor trying to figure out if you had a clot would basically just physically squeeze your leg.
You were talking about Hohmann's sign.
Right. The old bedside test where the doctor forcibly flexes your foot upward toward your shin to see if it causes deep pain in your calf.
Yeah, it was the gold standard physical exam for decades. But modern medicine completely abandoned it, and for very good reason. First of all, it is essentially useless from a diagnostic standpoint.
Because almost anything can make your calf hurt when you stretch it like that, right?
Yeah.
Like a cramped muscle or a ruptured cyst.
Exactly. The sensitivity and specificity are terrible. But more importantly, performing Hohmann's sign is actively dangerous.
How so?
Think about the mechanics. You have a fresh, gelatinous blood clot precariously clinging to the wall of a vein. Then a doctor comes along and aggressively stretches and squeezes the muscle surrounding that vein.
Oh, no.
Yeah, the physical manipulation can actually dislodge the clot right then and there, causing the exact pulmonary embolism the doctor is trying to diagnose.
It's literally squeezing a live bomb to see if it's ticking. So Hohmann's sign is out. Today, clinicians use a much more sophisticated algorithm. Our sources highlight this three-step pathway. First, instead of guessing, they use the Wells score, which is basically a strict mathematical checklist.
Right.
It assigns points for things like recent surgery, swelling, or cancer history to determine the mathematical probability that a clot is present. Then, they use a D-dimer blood test.
The D-dimer is fascinating. When a clot forms, your body immediately starts trying to break it down. As the clot degrades, it sheds these microscopic protein fragments into the bloodstream.
And the test looks for that.
Exactly. The D-dimer test detects that specific biochemical wreckage. So if the D-dimer is completely negative, you can be fairly certain there is no active clotting going on.
But if it is positive, you move to the ultimate tool, which is the compression ultrasound. It uses sound waves to actually visualize the blood flowing through the deep veins in real time. And here's where it gets really interesting, because this advanced ultrasound technology actually sparked a massive ongoing debate in the medical community.
It absolutely did.
Yeah.
Before ultrasound, a clinical DVT was just a DVT, and it was treated aggressively. But ultrasounds became so sensitive that doctors could suddenly pinpoint exactly where the clot was located.
Right.
This created a new anatomical distinction. They asked, was the clot proximal, meaning high up in the large veins of the thigh or pelvis? Or was it distal, meaning it was tiny and isolated solely in the deep veins of the calf?
And that matters because a clot in the calf has a much longer, more difficult journey to get to the lungs than a clot in the thigh, right?
Precisely. The data eventually showed that distal calf clots have a remarkably low rate of embolizing. In fact, the body's natural enzymes often just dissolve them over time without any medical intervention whatsoever.
Wow.
And this realization caused a massive fracture in standard protocols. Historically, the moment a clot was found anywhere, the patient was put on powerful blood thinners for months, but blood thinners carry a significant risk of severe internal bleeding.
So doctors started asking, like, are we risking a brain bleed to treat a tiny calf clot that might never cause a problem?
Exactly. This led to a controversial new approach called watchful waiting for isolated distal clots.
Watchful waiting.
Right. Instead of prescribing dangerous anticoagulants, some clinicians now opt to simply perform serial ultrasounds every few days. They just watch the clot. If it doesn't grow or move upward toward the thigh, they never medicate it.
That's a huge shift.
It was considered medical heresy 20 years ago, and professional hematology guidelines are honestly still actively debating exactly when to treat and when to watch.
It shows just how incredibly nuanced our understanding of blood clotting is becoming. And that nuance isn't just for hospital wards. It applies to all of us living our daily lives. Because the triggers for Virchow's triad are hiding in our everyday routines. For example, economy class syndrome.
Yes, the World Health Organization actually launched a massive study called the RIGHT Project to investigate that specific phenomenon.
And the data they found is just stark. I mean, if you were listening to this deep dive right now while sitting on a flight that is longer than 4 hours, your risk of developing a venous thromboembolism has roughly doubled compared to when you were just waiting in the terminal.
Because your calf pump is off.
Exactly. The pump is off, and the dry cabin air is dehydrating you, making your blood slightly thicker. So it is pure stasis combined with mild hypercoagulability.
And everyday life events affect that hypercoagulability too. Taking estrogen-based birth control pills, undergoing hormone replacement therapy, or simply being pregnant prompts the liver to produce more clotting factors.
Which is natural, right?
It is. It's the body's evolutionary way of preparing for the bleeding of childbirth, but it dramatically increases the risk of a DVT.
And then there are massive, unpredictable global events that throw the entire clotting cascade into chaos. The COVID-19 pandemic is heavily featured in these clinical notes.
The vascular impact of COVID-19 was a terrifying surprise to the medical community in 2020. Clinicians were seeing patients whose lungs were full of microclots and whose legs were developing massive DVTs, even when those patients were already on high doses of preventive blood thinners.
Wait, how is a respiratory virus causing blood clots in the legs?
It comes back to endothelial injury and inflammation. COVID-19 triggered what we call a cytokine storm, a massive uncontrolled inflammatory response by the immune system. The virus and the inflammation aggressively attacked the inner lining of the blood vessels throughout the entire body. So the body misinterpreted this massive systemic inflammation as widespread physical trauma.
Oh, wow. So it thought it was bleeding everywhere.
Exactly. It essentially panicked, thinking it was bleeding out, and dumped massive amounts of clotting factors into the blood. It created a hypercoagulable state so aggressive that standard drugs just couldn't stop it.
That is terrifying. But medical research also delivers incredible, positive surprises regarding how our vascular system works. The Jupiter trial from 2009 is a perfect example of this.
Oh, the Jupiter trial is one of my favorite anomalies in modern medical research.
Tell us about it.
It was a massive multinational study looking at a drug called rosuvastatin. Statins are widely known and prescribed exclusively to lower bad cholesterol. The goal was to see if the statin prevented arterial plaques from bursting and causing heart attacks.
But they accidentally discovered a massive benefit for the venous system.
Yeah. They did. When they analyzed the data, they found that the patients taking the statin had a dramatic, statistically significant reduction in venous thromboembolism.
Which makes no sense.
It confused everyone at first because cholesterol plaques do not form in veins, they only form in arteries. So how is a cholesterol drug preventing DVTs?
Right, what was the actual mechanism there?
It turns out statins don't just lower cholesterol, they're also powerful anti-inflammatory agents. They soothe the endothelium, the inner lining of the blood vessels.
Okay.
By reducing systemic inflammation, the statin essentially calmed the vein walls down, preventing them from sending out those chemical distress signals that trigger a clot. It was a total accident of research that proved how interconnected our cardiovascular systems really are.
It is incredible how a drug built for one side of the circulatory system ended up protecting the other, just by calming the environment.
Yeah.
So as we pull all these threads together, the core takeaways from this massive stack of research are incredibly clear.
Very clear.
First, Virchow's triad stasis, endothelial injury, and hypercoagulability is the ultimate blueprint. Every risk factor you will ever face traces back to one of those three pillars. Second, bed rest is no longer the cure. It is a profound risk. Early, active movement is the gold standard of prevention.
Movement is medicine.
Exactly. And finally, you cannot wait for obvious pain to warn you because a clot can be utterly silent until the exact moment it threatens your life.
And as you think about the silent, lingering nature of this disease, I want to leave you with a final concept to ponder that illustrates the true long-term stakes of a deep vein thrombosis.
Okay.
It is a condition called post-thrombotic syndrome. We focus so heavily on the immediate life or death threat of the clot breaking off and traveling to the lungs. But what happens to the leg itself after the crisis is over?
That's a good question.
Even if you were diagnosed early, even if you were given the right blood thinners, and even if the clot completely dissolves, the physical trauma of that clot sitting in your vein can permanently destroy those tiny, delicate one-way valves we talked about earlier.
Oh, no.
And when those valves are ruined, they never grow back. The blood can no longer fight gravity efficiently. It constantly falls backward and pools in your lower leg.
Wow.
For the rest of your life, you can be left with chronic, heavy swelling, persistent pain, and irreversible skin discoloration. It is the permanent structural footprint that a clot leaves behind long after it is gone.
Oh.
And it is the ultimate reminder that the true goal of medicine isn't just to survive a blood clot. The goal is to never let it form in the first place.